time as a doctor already.
Dr. Moneer,
Yeah.
because of my answer the other day, he walked out and he's like, you know what, I think you're a doctor, but you like us. He's like me, because I'm answering questions. I think you're a doctor, but you like me. Is it hot in here or just walk with somebody else?
It is hot. I mean, I don't know why I have the heat on. I'll say, can you do me a favor? Can you turn off the heat? Just turn it off. Yeah. And make sure it's on auto and off. Yeah.
Can you move your muscles?
Huh?
Can you move your muscles?
Yeah, with your hand.
Your muscle is scared. Your muscle is scared. It's like.
What's the difference between if you can control your muscles, like how is that possible? How you can control your muscles?
How can I control muscle?
I mean, like some people don't know how to do it. And some people don't.
Which muscles?
Like everywhere. The muscles there just.
Oh, you're just born weird.
This is real?
Yeah. Yeah, you have more fine movement, I don't. Okay guys, let's go. Let's go, let's go. Rabia, let's go. You need more coffee. Because at that moment you were sleeping. I'm like, Rabia, Rabia. She's like, okay. Alright. Now, let me go to gastric cancer. Was it gastric or pancreatic? Pancreatic cancer. Yeah. Yeah.
Oh, the camera's frozen.
I don't know why the camera is, but who cares the camera? The rest is okay?
Yeah, everything else is fine.
Okay. Now, pancreatic cancer. So we talked about there's two types of pancreatic cancer. Exocrine cells and endocrine cells. Okay. The endocrine cells, again, you know islets of Langerhans, right? They're alpha cells, beta cells, delta cells. True? If it's cancers or alpha cells, you'll call them alpha cells cancer or insulinoma. No, that's gluconoma, sorry. Insulinoma is made of which cells? Beta cells. So you can have insulinoma, you can have glucagonoma. Glucagon is gone. That's alpha cell. Okay. What if you have delta cells? Yeah, Ahmed. Adenoma. Good job. Okay. So we can have somatostatin adenoma, VIPoma, many ones, but the second most common one is gastronoma. I'll include that. Gastronoma is actually G cells, which are part of the antrum, but they can also be found abnormally in pancreas. Okay? Gastronoma is a cancer of G cells, which produce gastrin, correct? But guess what? The most common location is the pancreas. 66% of the time. Only about 36%, 34% of the time it is in the stomach and intestine. So in stomach it's not that common, although the origin of these cells is stomach. But you don't find in the stomach that frequently. Okay?
But why did you immigrate to the pancreas?
Just like how I immigrated from Afghanistan to here. Maybe better lifestyle. Yeah. Better lifestyle.
It's better for them.
Pancreas is better for them, yeah. They don't deal with the stress of H. pylori. For me, it was communism invasion, right? Bombing and stuff. H. pylori, same thing. So these guys. All right. Okay, so there you go. Insulinoma, gluconoma, gastronoma. Now, nonetheless, these are endocrine in origin. So this total of this endocrine cells, the percentage of total lung cancer is, I think, about 5%. Very small amount. Okay, and majority of them is insulinoma. Amongst the endocrine, insulinoma is by far the most common. Okay, and the second one is gastronoma. Gluconoma, not so much. VIPoma, not so much. Okay, good.
You said lung cancer.
Huh?
You said lung cancer.
Lung cancer?
Yeah.
Wow. I think I just meant that people should quit smoking, so that's maybe came out of my... Yeah, but I didn't mean it lung cancer. It's pancreatic cancer.
He's sitting in front of
I know. He gets himself in trouble. Okay, exocrine. Exocrine cell is 100% adenocarcinoma. Look, the exocrine is 100% what? Adenocarcinoma. But overall, it is 95% of the total pancreatic cancer. Okay? Exocrine cells is rarely squamous cells. Rarely. Most of the time it is adenocarcinoma. In majority of the cases. Okay, good. Now, see here, if you have gastronoma, the disease known as Zullinger, Allison, okay, syndrome. Okay, so it's a disease by itself too. Okay, you can call it pancreatic cancer, but you can also call it Zullinger-Allison syndrome, which maybe I should do after I finish this. Okay, so I'll start with the most common type of pancreatic cancer, the most severe form of cancer, which is adenocarcinoma, and then I'll go back to do those three, compare those three. Okay, so adenocarcinoma is very aggressive. It's malignant. Insulinoma, gluconoma might not be malignant, but this is almost always malignant. It travels, it spreads, very aggressive. Now, the adenocarcinoma is strongly associated with KRAS mutation. KRAS mutations. Tumor suppressor gene mutation like P53. Breast cancer gene 1 and 2. Okay. So it's commonly associated with those mutations. Now, endocrine cells, they're most associated with, if anything, with MEN1. Okay. MEN stands for multiple, M, multiple, please write it down, M, multiple, E, endocrine, N, neoplasia, multiple endocrine neoplasia, which means cancer multiple endocrine organs or cells. Now, this disease is inherited in the autosomal dominant fashion, men. So most of the time, endocrine pancreatic cancer have family history. There will be a family history. So there should be a family history. And it's common in young people because it's autosomal dominant. They will have a family history. Their cousin, their dad, their mom, somebody in the family might have this similar condition. Whereas adenocarcinoma is strongly related to what? Alcohol, smoke. Alcohol, smoke. Alcohol and smoke. Especially alcohol. Adenocarcinoma, the most common cancer of pancreas, is strongly related to what? Alcohol abuse. The rare form of pancreatic cancer, which is endocrine in origin, is usually related with family history. So if I tell you, you know what? A young 20-year-old came to screen himself for something because his dad had insulin problems, glucose problems. Okay? What are you going to think? Endocrine cells. At least either gluconoma or insulinoma. Or they had history of, or his parents have history of ulcer, recurrent ulcers. Yeah. Now, if I talk about an alcoholic patient whose family history is normal, in their 50s, adenocarcinoma. I mean, you're smart. There's no way I can trick you guys. Impossible. I can never trick you. You trick yourself. So don't blame me. Okay. Now, let's move on with this. Now, adenocarcinoma is most common Again, most of these cancers are very common in the head of the pancreas. So let's do this again. I'll go back to the same thing. And let's say we have, okay, pancreas. Okay, so pancreas should have its blood supply. Here is the duodenum. Duodenum around it, and you have the pancreatic duct and bile duct. Bile duct is green, pancreatic duct is red. These ducts coming. Okay, so just keep it simple. Now let's do a mass. In this case, let me do this one lighter so it doesn't confuse us. So there is a mass. If the mass of the most pancreatic cancers are where? Head of pancreas, right? So they usually will obstruct what? Bile duct. Okay, now the pancreatic head cancer in itself is responsible for acute pancreatitis, chronic pancreatitis, and hepatitis, and cholecystitis, and cholangitis. Let me tell you the complication of the adenocarcinoma. Let's start with cholecystitis. Cholecystitis. Yeah. And the thing is, because cancer grows slowly, so it's not suddenly, but one day can obstruct. So nonetheless, when you have, in this case, the person, so all pancreatic cancers, patient will present with what? Epigastric pain. Okay. Huh? Jaundice. In this case only. Very good. Jaundice only if there is obstruction of the bile duct. Okay. But it's a huge thing. Weight loss. Weight loss. Big time. Okay. Weight loss big time. But you know, there's something very important with all adenocarcinoma. You know, whenever you hear this term adenocarcinoma, think of thrombophlebitis. Migratory thrombophlebitis. Migratory thrombophlebitis. It should be in your books. Migratory thrombophlebitis. What does migratory means? Moving from place to place. Thrombosis, phlebitis, inflammation of veins. So this could put you at risk of patient having thrombotic events. Venous thrombosis, venous inflammation, veins. So migratory thrombophlebitis is a huge issue here.
Why is that, doctor?
Adenocarcinoma, they produce prothrombotic factors. They produce prothrombotic factors. Okay? Migratory thrombophlebitis. Okay. Now, so these cancer can produce, for example, too much mucin. Mucin is also puts you at risk of thrombotic events, platelet aggregation, thromboxane A2, factors like that. Now, the question is, they're produced mostly in where? In veins. In veins, because the cancer blood will be carried by veins, not by blood. Arteries brings blood to the cancer cells. Veins will carry it away. So it's venous thrombotic event. That's why phlebitis. Phlebitis means inflammation of veins. Because the cancer factors will be carried away from cancer or tumors by what? Veins, not by arteries. Arteries will bring things to it. Therefore, these factors, as they go along the veins, they will cause inflammation. They will cause thrombosis. But as they travel today here, tomorrow there, next day there. That's why it's migratory. Because venous blood depends where you have the most concentration of these thrombotic events. Okay, so huge. Remember this, migratory thrombophlebitis. So they can have superficial veins. You will see inflammation along the venous line. So you will have redness and rash along the course of that vein, superficial vein. And you can clearly identify it. The rest of the part is okay. 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 So weight loss, jaundice, epigastric pain, all of these will be complication of pancreatic cancer. Now, pancreatic cancer can travel almost everywhere. It's very aggressive. So usually it's lethal within 5 years. But now, as soon as you see jaundice, you should know this. Look, if I ask you a question, I give you a 50-year-old coming to clinic or a hospital or your office, and they have jaundice, but they also complains of epigastric pain, and they have weight loss over the last 3 months, about 10 pounds, and they're telling you, like, I don't know what's wrong with me. And I say, you know what? I suspect there is cancer, pancreatic cancer. What's the most common location of this cancer? Head of the pancreas. Head of the pancreas, close to the ampulla vader. As soon as there is obstruction of bile duct, you have to think of head of pancreas. Now, if I tell you, that the person had tail cancer, the cancer was in the tail, what organ is most likely affected by this cancer or invaded? Spleen and kidney. Spleen and kidney. Very good. What if I tell you it's protruding upward on the upper edge of pancreatic body?
Is it the
Splenic artery. Good job. Splenic artery. Okay. And the bottom. Yeah. Okay. So you should be aware of that. Now, pancreatic cancer can cause constipation, obstruction, many things. So it depends. Ascites. Complications are tremendous. Now remember, let me just take this away from here. Pancreatic cancer, that's adenocarcinoma, the symptoms are completely different. Let's compare these symptoms to other symptoms. Now, symptoms caused by insulinoma. Too much insulin. Let's label them 1, 2, and 3. So I can say 1. What would be the symptoms of insulinoma? Hypoglycemia. Excellent. Hypoglycemia. Hypoglycemia accompanied with C-peptide. Very good. C-peptide, if you want to measure it. Okay. Hypoglycemia. And the symptoms of hypoglycemia are what? Irritation, anger. You're hungry. You like, if you have, people who have, like they go to a restaurant. I'm waiting here for 20 minutes. Give me my food. If they go home, they tell their brother, their sister, their wife, their mom, their whatever. What do you think? I'm hungry. Give me my food. Because the brain is not functional. They ain't getting enough glucose. Almost always, most people get irritated, angry, impulsive when they're hungry. They become impatient. I didn't hear somebody say something. Question? Okay. All right. They get irritated, and that's true. Test yourself. Unless you voluntarily decide not to eat. When you voluntarily decide not to eat, it's a little bit different because you have some control. Even then you get irritated unless you have the discipline not to. Unless you benefit, maybe you want to lose weight. Maybe you want to become anorexic. Then, yeah, sure.
Snickers ads.
Yeah. So anyhow, now hypoglycemia, usually the patient will be complaining of irritation. Now this hypoglycemia is not 24/7. Insulin is not produced 24/7.
It's episodic.
It's episodic. So the patient usually be complaining of what? Blurry vision, headache, irritability, anger, complaints, okay, demands. Those are the things that the question will be talking about. Hypoglycemia always causes those things, always. Again, unless you are trained enough and you have control over yourself, most people are not. So that's what the complaint will be in clinics. Okay. All right. Number 2, gluconoma. Yeah, diabetics. It leads to diabetes. They'll create the state of diabetic state. Okay. Number 3, gastronoma is going to produce what? A lot more gastrin. There you go. So ulcers. Specifically, whenever you have ulcers in the jejunum or ileum, it is 100% gastronoma. These ulcers are recurrent, retractable. They don't respond to medication usually, especially to H2 blockers. Remember, gastronoma-induced ulcers, they could respond to PPI, but not as good. Okay, how long are you going to take the medication? Unless you remove the tumor, you will always have increase repetitive exposure to acid, right? So they don't respond well to medication. Okay, they don't respond well to medication, number one. Number two, they don't respond at all to histamine, antihistamine. They will respond to PPI, but not as good. Okay, but to antihistamine, not so good. So it's recurrent ulcers, especially if you do endoscopy, you find ulcers in the jejunum or ileum, it's done. To me, it's guaranteed. For you, it should be guaranteed. In reality, there could be different things, but I'm talking about, like, you know, just to kind of save you time and make you alert for the exam. Yeah.
So where's the acid coming from to cause ulceration?
All the way from your stomach.
Your burner and cells are not.
Not enough.
Because it's too much.
Now, if I give you a small amount of spices, maybe you can coat it with sugar, maybe your saliva can dilute it, but if I give you this whole bottle to drink of spices, is your saliva enough? Nothing will neutralize it. So some will reach somewhere. So it's the quantity now. When you talk about gastronoma, we're not talking about small amount of gastrin. Remember what I told you?
14 to 1,000.
Yeah. What did I tell you? What's the normal concentration of gastrin? Less than 40 nanogram per liter. And in gastronoma, it's over 1,000. Over 1,000. Okay? Alright, so overall, there's too much acid produced that your body is not able to handle it. So it will reach a lot of places, yeah.
How come PPIs are not effective?
Now, PPI will simply block the receptor, but the receptor will be replaced with a new receptor. The pump will be replaced with new pumps, and then they will release acid.
So it's upregulation.
Yeah. And sometimes acid can just leak too when there's too much concentration. There's different ways.
Would this also cause metabolic alkalosis?
Yeah. Now, gastronoma will not cause metabolic alkalosis, it will cause metabolic acidosis. Gastronoma will cause metabolic acidosis.
Why?
Because now, when you have too much acid going in your stomach, they can be reabsorbed. It's PPI that will cause it. Okay? Yeah. Okay. So again, if you have acid in your stomach, they're able to be reabsorbed.
The concentration is high.
Exactly. But if you cannot produce acid, their absorption, when you vomit, for example, when you vomit or diarrhea, you lose a lot of acid, so it leads to metabolic alkalosis. But in this case, no. Yeah. Okay. All right. Okay, so now you should be smart enough, you know the rest, that in the case of adenocarcinoma, markers, there is no specific markers. In case of insulinoma, you look for plasma insulin being increased, C-peptide increased, and blood sugar will be low. For insulinoma, blood sugar should be low, blood insulin should be high, blood C-peptide should be high. Okay? For gluconoma, glucagon should be high, glucose should be high, okay? And what should be low? Insulin, cortisol, and everything else should be low. Okay. Now in gastronoma, you will have increased HCl in the stomach, increased acidity in plasma, and less carbon dioxide because it has to compensate, right? And of course, you'll look for gastrin as well.
And ileum or jejunals.
Now gastronoma gives you diarrhea as well. Why is that? It gives you malabsorption.
Damaging
Yeah.
the intestinal brush border.
Good. It does two things. Very good. Very good. It does two things. When you have too much acid reaching the duodenum and jejunum, which is not designed for acidity, the pH of intestine should be about 7.87, around that area, not 2 or 3 or 4. So the gastric acid coming from stomach, from parietal cells, with a stimulation of gastrin, when they reach the duodenum, number one, they will start burning what? The Brenner's gland. The Brenner's, I will call it burner. It burns the burners. So they will produce less mucus now. Further, that means the next time, the quantity of acid that can reach further down the duodenum increases. And then there it will start denaturing what? Brush border enzymes, which is what? Enterokinase, dipeptidase, and sucrase, lactase, and maltase. That's one thing. So that will decrease absorption, so lead to malabsorption. In addition to that, it will also cause denaturation of what? Pancreatic enzyme. See, pancreatic enzyme gets activated when? When you have basic pH. When the pH is acidic, what happens to them? They get deactivated even further. They denature. So overall, there's two steps with malabsorption. Pancreatic enzymes are defective, not in the pancreas, but when they secrete into the duodenum, because the environment there is very acidic. They'll be destroyed. Plus, the villi microvilli is destroyed. So this can lead to malabsorption. Okay?
Does it get to destroy normal flora also, or it doesn't get that far?
Yeah, it does. Yeah. So then you can have vitamin deficiency as well. Yeah.
For gastroenterology, can patients get Barrett's like that?
Can they have Barrett's esophagus? Possibly. Yeah. 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 If the reflex is there, yeah. Okay. That all depends on the compatibility of LES.
So if they do have Barrett's in that case, would that be good for them, having it before?
No, if they have GERD, it will get worse. In gastronoma, GERD gets worse. Okay? Yeah. Reflex tendencies and acidity will increase. Will cause more damage. Because you have more acid that can go up. Okay. Alright, treatment. For exocrine adenocarcinoma, you have to remove it. You have to resect it in the chemoradiotherapy. That's for adenocarcinoma. For endocrine, insulinoma, gluconoma, gastronoma, you also have to remove them. Okay. Now, some of them are not always malignant. Gastronoma is malignant. Okay, whereas insulinoma and gluconoma is mostly benign, but they can be malignant as well. So benign, you just remove them, it's okay. You don't have to necessarily do chemotherapy. Okay. Alright, you can do CT scan. CT scan will show a mass in the pancreas, either in the head or tail or body. Right? Okay, that's for this. The last thing, what time is it anyways? We have time, right? Okay, 10:30. Pancreatic cyst. Yeah.
Cystic fibrosis can lead to pancreatic cancer?
No. The only time if patients survive that long enough, because of chronic gastritis, yes. But not directly. You will have to go to chronic gastritis. Okay? Yeah. They're at risk. They have more risk than general population, yes. Yeah.
There's, I can't remember the name of it is, but isn't there a disease with its children? It's called cystic fibrosis, and with adults it's, I can't remember
Same disease?
the same name.
No, cystic fibrosis. Maybe a disease that presents similar. I don't know. Yeah, I'll try to think. Maybe, unless you're mixing rickets in Malaysia or osteomalacia, which is vitamin D deficiency. But yeah, look it up. Okay, pancreatic pseudocyst. It's a cyst where? In the pancreas.
It's a pseudocyst.
But it's a pseudocyst. What does pseudocyst mean?
Doesn't have all the layers.
Doesn't have all the layers. Good job. And what are all the layers?
Basement membrane that
Yeah, it's only mostly epithelium. Yeah. So it would be a cyst that's more because of damage. You know, like when there's damaged cells and you wall them off so they don't go to the rest of the pancreas, don't spread. So it's traumatic cyst. Okay, so now pancreatic pseudocyst is a complication of acute pancreatitis, believe it or not. It's a complication of what? Acute pancreatitis. Let's say a patient had acute pancreatitis. A month later, they come and they complain. I have some pressure in my left side of my abdomen. A pressure. And then you palpate, there's a mass. That's not solid, that's most could be fluctuating. So, that's pseudocyst. It's always a complication, almost always a complication of what? Acute pancreatitis. In acute pancreatitis, what happens to tissue? Pancreatic tissue. They're damaged, they're dissolved. And then to prevent, see, the pancreas is, now your body is very smart. I mean, you're smart. Let's just talk about you, not your body. You're very smart. You're designed very delicately, very carefully. So if pancreatic is being auto-digested, shouldn't there be a mechanism to prevent spread of that auto-digestion? It's common sense, right? So we are designed to protect ourselves from death. We're designed that we should survive forever. Okay, that's our goal. Even like, that's why we love life so much, right? We want to live forever. I mean, I do. I know all of you do. If you deny that, let's make an appointment with psychiatrist. Everybody loves life. Everybody, and they should, and it's the right thing. So pancreas also wants to live. Each individual cell wants to live. And that is translated in your behavior, in my behavior. Each individual cell wants to live, doesn't want to die. It's designed for living, not for death. The definition of life means what? Living. If you don't do it, you're not doing the right thing. So now, if pancreas cells are dying, if they're dying, that means there is a mechanism to prevent the spread of those cells. So if it's a group of them dying, you don't want the whole pancreas to die. So what happens? Now inflammatory cells will come, macrophages will come, neutrophils will come, and they will start digesting the dead tissue, and they will surround the dead tissue. It prevents it from spreading all over the place. And the neutrophils also are rich in what? How many of you know of emphysema in children? What's the cause of emphysema in children? What's the cause of emphysema in adults? Most common cause? Smoke, 100%. Let's say 98. But now, no. What's the most common cause of cirrhosis and emphysema together in children? Antitrypsin deficiency. Antitrypsin deficiency. Have you heard of trypsin, guys? Trypsin, you heard of it, right? Who makes trypsin? Pancreas. What does trypsin do? It's a protease. So what do you think antitrypsin does? It disables, inhibits, and destroys trypsin. So it prevents damage to proteins. So now when neutrophils come, they're rich in antitrypsin. When they come and then they see there's trypsin activating crazy, going out of hand, what are neutrophils going to do? Degranulate and release as much as antitrypsin they can to prolong your survival. To prolong your survival. So what they do is they will surround that area of damage, prevent its spread to the rest of it, and then this can become a cyst. So cyst is dead tissue in a balloon-shaped structure. That's what cyst is in this case. It's a pseudocyst because it doesn't have the true layers of a cyst. No epithelium, no basement membrane, no smooth muscle. So this cyst is actually made of, it's almost like an abscess. It's called cyst. It's typically an abscess, but there are no infectious agent. Could it become an abscess? Of course, of course, of course. So after acute pancreatitis, the damaged tissue, the debris is all put in one area, and then it's surrounded from spreading. Look, none of us like to have garbage spread all over the house. It will make us sick. So that tissue, you can think of it as garbage. It's not functional, it's not useful for you. Okay, so it's all of that, especially the enzymes. The enzyme, they're all, there'll be a fibrotic coat, a fibrous coat around it. And it'll be built into a spherical shape, so none of this can leak anywhere else. That's a pseudocyst. So it's natural for you even to think. This is a natural progression of the acute pancreatitis. There should be a cyst. There should be. It's a good thing. But it develops, not always. So whenever you think of pancreatic pseudocyst, think of acute pancreatitis being the cause of that cyst. And if that cyst becomes infectious, then it becomes an abscess. Then it'll become an abscess. So pancreatic abscess. So let's say acute pancreatitis can become pseudocyst. Pseudocyst can become an abscess. We discussed acute pancreatitis already. Now, a pseudocyst will be just a mass. This mass can cause pain, can cause discomfort, can give you the sense of something being there, pressure. That's what it would be. But it's painless. The mass is painless. The mass or the cyst is painless. The issue is sometimes you can mistake it for what? Pancreatic cancer. Now, if the pseudocyst is compressing the ampulla of Vater, what would happen? Jaundice, excellent. If it goes and compress the spleen, the kidney, everything. So it could give you similar symptoms. There will be some sort of pressure. So it depends what's the location of the cyst. If it's abscess, now you have a mass, like before. Now this mass is painful. Very painful, very painful. I'm not just joking as a painful. So there is a mass. This was painless. Cyst is painless. But now abscess is so painful. If you touch it, the person will say, "Ah." I mean, on the left side, right? Ah.
It's okay.
I want to be accurate, because I'm accountable. So they actually jump, and they'll have high fever. High fever. Abscesses are usually not responsive to antibiotics. So you do your best. You do your best. You do your best. At least I woke up, that's good. You do your best to treat them for 2 weeks or 10 days. Hopefully, within 10 days, if the abscess is gone, good enough. If not, then you have to do surgery to remove it. So, know the difference between a mass. A mass in the pancreas can be cancer, can be cyst, or it could be an abscess. Very good. Okay?
It's more likely to be cyst and abscess if they had acute pancreatitis.
Oh, abscess is rare.
Oh, really?
Yeah.
Terminate.
But it could because of bacteria. Yeah.
CT scan differentiate.
Excellent. Now, what would you do if somebody comes and complains to you, what, I have this pressure feeling in my left upper quadrant. I have a feeling of pressure. But you palpate there's a mass and it's painless, right?
Is an MRI better for fluid?
No. Ultrasound. Yeah. MRI is better for white matter of brain, white matter, in more solid tissue. Now, so if you have a mass, you palpate a mass, you don't know exactly what the mass is. You're concerned, is this cancer or is it a cyst? What are you going to do? Do ultrasound. If there's fluid air level, ultrasound will do better. CT scan will do better. But usually for cyst, ultrasound is better than CT scan. Okay, so you can do both. Because ultrasound you can do enough to diagnose it and see it, and it's less expensive, it's faster, it's simple. CT scan is difficult. Patients don't like it. Unless you own a CT scan lab, then you'll prefer that for your patient.
Consist with
Ultrasound, the stomach would cover his spleen.
Yeah, you can still see it. Yeah. Okay. Very good. So now, what are you going to do? Once you see there's a cystic mass is unlikely to be what? Cancerous. If it's a solid mass, most likely it's cancer. If it's cystic mass, most likely it is non-cancerous. But we still don't know. So on ultrasound, you will see there's a mass. And then you will do fine needle aspiration of that mass or laparoscopic examination of that mass. You have to do biopsy it anyways. Again, if you suspect it's cyst, you can actually drain it. But remember, you have to be careful. If there's still some active enzymes, you don't want them to leak, right? So you have to be careful. If it's abscess, you have to be careful because you don't want it to cause infection. Okay? Very good. You're smart. Just think freely, please. Please learn how to think freely. Don't restrict yourself with limitation of knowledge. Sometimes because we think textbook-wise, try to not become a textbook type of student. Use this knowledge and apply. And think broadly. Okay? Open your horizons. Ooh-ah. Okay. All right. So there you go. Treatment, debridement for abscess and for cyst. Debridement means you have to wash it, remove the dead tissue. You have to remove the dead tissue. The good thing with cyst is, if you leave it, if it's not in danger of anything spillage or infection, eventually all the enzyme will become deactivated and the tissue will be absorbed by your body. Okay? I mean, if it's emergency, you can remove it. So, Yahoo.
They don't put the drain inside the cysts or the...
You could do it. That's what I'm saying. If you don't have to, if you really have to, because remember, surgical procedures cause more pain and stress on patient than just a silent cyst, not abscess. There's no such thing as. Do you see what I'm saying? Yeah. So you will decide based on the patient's condition. If you think this is going to degenerate in a month, no, don't need to do any procedure. Why scare them? Why charge them? But as I said, there's crazy doctors. Do you guys know that there was a physician in Michigan? What was his name? Amin something, right? I think he was orthopedic surgeon, one of those. He had billed patients for things that they had no idea, and he had made over a period of 10 years, $15 million. So of course IRS will know. Like, a physician is not supposed to make that much money unless you have multiple businesses. Yeah. Oncologist, there you go. Yeah. Yeah. Is he in jail now? Oh, the case is still pending?
It's not just one,
Actually,
there's three of them.
there's another case
Wow.
in Indiana. Cardiologists
Same thing, huh?
for cardiologists. They were opening hearts for no reason.
Crazy. Crazy, crazy, crazy.
Money, you just need money.
Yeah. And you know what the thing is? This is, I hope, guys, and I hope, I love ethics. I do want to teach ethics to you guys too. I'm thinking of, like once a week, once a while. The thing with fame and money and power is, it is very, very, very infectious. It can get the best of us. None of us are immune to it. It's impossible to be immune to it, but so just do your best. We don't want to be, at least we don't want our students to be one of those. But it's sad, like you take an oath, you take a promise that you will actually alleviate pain. It's crazy. But not only are you depriving them of financial supports and things like that, and you're depriving them of like causing this severe mental pain. You have cancer, imagine. I don't know, those of you, if you have gone through something, just a slightest indication, if you think you're at risk of cancer, you won't be able to sleep. I'm telling you. I've come across many patients, they're young, and I'm telling them, no, there's no chance. But just because they read on Google, or just because a medical student told them something, they believe them more. Because why? It's the fear. It's not that they trust them more, it's just the fear. The fear of something like, oh, cancer is the most severe thing. And they don't sleep. For 2 weeks, they're depressed. You see their skin is pale.
They will get cancer.
Yeah, they do. Yeah.
No,
So.
come on.
And that's true. So actually, my brother-in-law, and he, as I said, he suddenly decided he was he wanted to change his lifestyle. So he went through some drastic changes. He wanted sudden changes, and he worked out so much. This is recording. Let's not do this.
Yeah, listen.
Let's go. And all of this comes from what? Finding information on TV shows or Googles and stuff like that, and you think you know everything. So it's okay. All right. Next thing is, let's talk about something with pancreas known as annular pancreas. Accessory pancreatic duct. See, I can talk about my relatives, not a problem, because it's okay. I'm responsible, but I cannot talk about it. But you will see crazy people. The worst thing is when doctors themselves, highly qualified people, get some sort of abnormal condition. I don't know if you see, if orthopedic surgeons have chest pain, oh my God, you can't deal with them. You can't deal with them because they want to know everything, yet they don't have the knowledge because they've been practicing only carpentry. So vice versa, if somebody has shoulder pain and is a cardiologist, or psychiatrist has acute appendicitis, you should see them. Oh my God, they're like little babies. And it's very hard to treat them and diagnose them because they think they know everything, but yet they cannot treat themselves. So, and they fear the most because they know the knowledge. When you have knowledge, you can get very scared too, because you know what they can do. So excessive pancreatic duct, pancreatic divism. Pancreatic divism doesn't mean pancreas dives in water or something. Division. It's a division problem. These are all congenital defects, so therefore we have to know embryology of the pancreas. Embryology of the pancreas, okay? Embryology of the pancreas. Where does pancreas come from? Huh? Foregut. Good job, foregut. See, in the foregut area, there will be two ducts, or two buds. It'll start budding off. So there'll be one bud, which is known as the dorsal bud. B-U-D, right? Divism. You can call it divism. Same thing. I'm missing something, an I. And then there's anterior pancreatic bud. Okay? Or ventral. See, the ventral pancreatic bud has two parts. It has the pancreatic bud and it has hepatic. Okay, so pancreatic and hepatic. So the unshaded one is liver. I'll put liver. And this one is anterior or ventral. What's the difference between anterior, ventral, and frontal? Is it? Good. Yeah. Nobody else responds. They don't know. So me and you know. You know, we'll take credits for it. Bonus. There you go. I know Muhammad doesn't like bonus. Yeah, he doesn't like bonus. Every time I want to give him bonus, he's like, no, just throw it back at me. Like, here you go. Take it. Okay. Oh, how was the race? Did you guys race?
I won.
Two stubborn people. Oh my God. How did you guys even manage to race?
Well, he put me in the pothole area.
I know it.
Yeah, he was foxy.
He is foxy.
The bad friend.
Anytime, I still gonna be.
He was dying that day.
You almost
Yeah.
died after he was.
I know.
He was breathing for 3 hours.
Yeah, I looked at him. It's like I never raced and he looked like he ran around the world.
Okay, I'm gonna give you guys something to work at. Now, next week, there's a competition between the two of you in terms of education.
Wow.
Okay? So I'm gonna give you a topic, and I'm gonna give you a topic. Who does the best presentation to the class?
No, I gotta present this
No.
weekend, man. It's enough.
After you come back. After you come back.
That's not fair.
It's okay. It will only improve you. Don't be afraid of. Remember, you said you're never afraid of anything. Are you afraid?
I'm not gonna.
Chicken.
Thank you. There you go. Honey. No, honey, no. Okay. All right. Let's use their energy in the positive way. Okay. Not in breaking their legs and having heart attack like him the other day.
I didn't have heart attack. I ran before with him and I beat him too.
I'm sure you beat, but you didn't beat yourself. You really beat yourself
He
too.
almost killed himself.
Make them make the presentation while they're running.
That's true.
That's not crazy.
Then we have to run with them. All right. So look, guys. So there, think about it. This is so. Just picture on this area. There will be a bud. This bud will start growing. And become pancreas. Okay, that's exactly what happens. But I just want to write the names for you first. There's two pancreatic buds, anterior and posterior or dorsal. Now remember that anterior is unique. It's attached to what? To hepatic duct. So they're together. They come from the same source. Okay. So let's increase this bud. This bud will increase in size, and it will become anterior pancreatic leaflet or leaf. It's no longer just a bud. It grew to become a leaf. Make sense?
Is it dorsal or anterior?
Dorsal. And then the dorsal one will grow as well. Okay? So this one is ventral. Let me label it for you, because I used to say a lot of things. So V and D. Okay? Now, of course, I'll use for liver the color of liver, and the hepatic duct will grow to become what? A liver. Right? It will become a liver. That's when they mature in adults. This is what it will become. But let me ignore the liver. So you should just remember liver. Is that okay? I would delete the liver because we don't need it anymore. I'll keep it. That's fine. Now, what happens is the ventral duct will rotate about 90 degrees to meet who? The ventral and dorsal will have to meet. Okay, it will rotate. And let's see if I can do that. Okay. That was not rotation. Uh-oh. There you go. Wow. Seriously? Okay, never mind. So it will rotate and it will come here, right? I wanted to show it animation, but I guess no. You see these guys, these program providers, they're so cheap, they trick you. I paid for the program, but now they're saying no, you have to do subscription, blah, because they took the things that I used to be able to do. They took it out. Okay. So remember, both of them go to the same side, right? Both of them go to the same side. Now, of course, this duct, I'll use green for it. The ventral pancreatic butt should have ventral duct. Ventral pancreatic duct. And the dorsal one should have dorsal pancreatic duct. Is that true? Each of these pancreas should be attached to the duodenum by a duct. Because they bud off from there, so they'll be attached. They'll be attached by ducts. So if these two, eventually these two buds and ducts have to fuse to make one pancreas, one bud, one duct, and one pancreas. If they fail to do so, so that means what would you get? Two pancreatic ducts, pancreatic divisum. So if the pancreas don't fuse, you see in this case you have two buds and you have two ducts. Okay, you have two buds and two ducts. That's pancreatic divisum. So both pancreatic will be separate. Two anterior and posterior pancreas, they're both separate entities. They didn't fuse together. But what else could happen? What could happen is eventually, so the dorsal pancreas, so most of the tail and body of the pancreas comes from where? From the dorsal pancreas. The head of the pancreas is primarily from where? The ventral pancreatic bud. Now it fused. It became one pancreas. So at least the two leaflets fused. If they don't fuse, it's pancreatic divisum. If they fuse, but the ducts still stay the same, they don't become one duct, the posterior duct doesn't dissolve, then guess what? It is accessory pancreatic duct. Whoa, I erased it. It is accessory pancreatic duct. So the ventral duct, remember the ventral duct is attached to what? Gallbladder and bile duct. It should stay. Okay? Let me do it this way. Let me tell you first how it develops and then we can make sense out of it. Okay, so are you okay so far that you have the two pancreas, they're fused? The bodies of the two pancreas, they fused. Make one pancreas, right? So each pancreas will have its own duct. This pancreas has its duct and this pancreas has its own duct. Okay, now the one in orange was posterior bud or posterior pancreatic duct or posterior pancreas, correct? Okay, so the distal, the proximal 1/3, the proximal 1/3 of that pancreatic duct will disappear. This area will disappear, will dissolve. Wow, why can't I have the right blue? Okay, so this will dissolve. So this pancreatic duct will dissolve. The posterior 2/3 will stay the same, but the anterior 2/3 will dissolve. And then the green and red will fuse together. They'll fuse together. So which means half of the pancreatic duct is made of what? Dorsal duct and half ventral. Okay, this is what it would be. So this would disappear. And I should use different color for the duodenum so we can see them separate. There you go. So now the distal 2/3 of pancreatic duct is made of what? Dorsal duct. The proximal 1/3 is made of what? Ventral duct. That's the mature pancreas. And if you think about it, remember that naturally in the duodenum area, naturally, if this is the duodenum and here is the head of pancreas, naturally, we're talking about an adult pancreas. Remember, there's two ducts that fuse together. Pancreatic duct and bile duct. So the only duct that should be closely attached to duodenum should be the what? The bile duct related pancreatic duct, which is ventral. So the proximal part of the duct is the ventral duct. The distal part is dorsal duct. So dorsal is, this is the dorsal duct in red. Green is ventral duct. Okay, so the dorsal duct should degenerate proximally. Distally it should stay the same. Now the question is, if the dorsal duct does not degenerate, which was red one, right? It doesn't degenerate here. It's accessory pancreatic duct, that's all. The pancreas has two ducts emptying into what? Into duodenum. Okay?
Does it cause any issues?
No, not really. Not a big deal. It's asymptomatic. It'd be anatomical finding. It'd be surprise finding for you. You don't expect such thing. That's all.
Surgery or something?
Yeah. It would be incidental finding. No symptoms. Asymptomatic. No big deal. You don't have to do anything about it. Same thing with pancreatic divism. You don't really have to do much about it. It's just finding.
Is there like an anastomosis between the two ducts? Like would
Yeah.
having an accessory duct reduce the chances of acute pancreatitis?
Yeah, so very good question. In this case, when you have this duct draining the head, right? And the other duct draining the tail body, so if there's a mass that obstructs one duct, at least you have the other duct. So you might not have acute pancreatitis at the same rate or to the same severity, yeah? Okay, annular pancreas. Annular pancreas, let's go talk about that. Whoa, okay. Annular pancreas. Remember when we talked about the ventral duct? See, the dorsal duct stays in the same position. It's the ventral duct and butt that rotates, right? So if the ventral duct comes and it rotates around the esophagus to meet together.
Esophagus or the
Duodenum, sorry. Duodenum. If it goes around it, that means what happens to duodenum? It's obstructed. It's obstructed. So this is annular pancreas. The two buds wraps around the duodenum, the second part of duodenum, and it causes duodenal obstruction. And that's symptomatic. That is symptomatic. So that's known as ring pancreas or annular pancreas. What are the symptoms? Of course, that means there will be no food passing beyond the stage, right? So there should be obstruction to, this is obstruction to food or digestion. Now, the problem with that would be that means you will regurgitate and vomit. So there should be vomiting.
Simulates atresia.
There will be vomiting, huh? Now, it could be non-bilious or bilious, right? Most of the time it's bilious because the obstruction is after the ampulla vader. Okay, so you can have both. You can have both, depending which area is obstructed. Before the bile duct enters the duodenum or after the bile duct enters the duodenum. Yeah.
This simulates duodenal atresia.
It simulates duodenal atresia very closely, yeah? Very closely. Okay. So there will be vomiting, and there could be jaundice too. Okay, there could be jaundice, but vomiting is there. So these two are always there. Okay, so now jaundice depends if the ampulla vader is obstructed or not, right? But vomiting, that could be bilious vomiting, and it depends on what? Bilious vomiting means, is bile in that vomitus? Yeah, if it is, that means the ampulla vader, that means the obstruction is after the ampulla vader. And that's what I'm going to ask. So I give you this scenario and I say, where exactly is the obstruction? Before the ampulla vader or after? And you should know. Okay? These are congenital defect. What are you going to do? You have to do surgery and loosen them up. Okay? Alright. Now, we are done with pancreas. Okay, we're done with pancreas. Anything else about pancreas?
What about pancreatic?
Huh?
Pancreatic divism.
Same thing. I told you it's just abnormal finding. It's not symptoms. That means the two leaves, if this is the duodenum, the two leaves of pancreas never fused.
Oh, okay.
That's all. That's pancreatic divism.
Okay. But it doesn't have any problem.
Shouldn't.
Trauma.
Yeah.
Trauma for the pancreas.
Pancreatic trauma, yeah, I'll do that. Yeah.
Can you define bilious vomiting for some of those things?
Okay. Very good. So vomiting. See, vomiting, when somebody, before we take a quick break, when I come and tell you, you find doctors, I'm like, I'm vomiting. What's your next step?
See,
Ask me.
Ask if he is
Ask me.
defecated.
Ask me. I am the patient now.
Does it taste sour?
Does it taste sour? So you want to know the taste of vomitus. Very good. Taste. Okay.
Color?
Color. Excellent. Color. Now ask me the question. Don't just...
Where's the color come from?
There you go. Good. Anything else? Projectile? Okay. Yeah, sure. But let's say amount. Quantity.
Would you ask how frequent?
How long after the meal?
Frequency, how frequent the vomiting?
Yeah, you could do that. But we want to know the quality of vomiting. And then you can say odor. Those are the things you should be concerned about, okay? Now, taste. If it tastes like acid or sour taste, what are you going to think? At least gastric acid is involved. So this vomiting is coming deeper than the esophagus. It's not just regurgitation. It's not undigested food, right? Okay. Color. What are some colors?
Pink.
Pink?
Yellow.
No, he's right. Yellow?
Coffee.
You mean pink like, you know, those girls who wear those things that on the butt it says pink? All right. Am I being recorded?
Yes. So.
That's good. Okay. So pink, yellow, anything else?
It says green.
Green. What kind of green?
That's her favorite color.
I know it's her favorite color. What kind of green? Dark green. Not yellowish. Dark green. Dark green. Any other color? Okay, so let's say chocolate. Chocolate color. Okay. Amount. Do you care for how much somebody vomits? Okay, is it a teaspoon? Is it the cup? How much is it, right? Okay, good. Odor.
Smell.
Does it smell like acid? You know, the acid in citrus smell is different than malodorous smell, right? So look for this. But let me go back to this, the color part, because that's what they're asking. Okay, if it's greenish, dark greenish, that means bilious. Bilious means it has bile in it. Bile. The area, remember, if this is the duodenum,
After the sphincter.
very good. Bile duct enters over here, right? And then that's where bile is released. If you have vomiting before this area, above this area, of course it would be non-bilious vomiting. It wouldn't contain bile. When you use the term bilious vomiting, meaning it contains bile. Any vomiting that comes from below this area will be bilious vomiting. Okay? So that's how you should be thinking. So it kind of gives a good anatomical chart to see where exactly is the cause of this vomiting. So that's for this. So that was bilious vomiting. Bilious vomiting means what? Bile staining vomit, bile containing vomit. Now, if you have pink vomiting, that means it is most likely Mallory, wise tear, fresh blood, anywhere. But it's most likely upper GI. Okay? Fresh blood. If it is chocolate color, that means it's most likely varices or dark blood, venous blood, old blood. Okay? If it's yellow, most likely infectious. Most likely infectious. There's some infection or something, or it's just mucus. Okay? Okay, let's take a break. If you have questions before the exam, so we have half an hour before the exam to answer your question, otherwise we'll start the exam.